Welcome everybody. Before I begin, I would like to acknowledge the traditional custodians of the land that we meet upon today, the Whadjuk Noongar people, and I pay my respects to elders past and present, and also from the lands upon which you may be listening in on today as well. So thank you very much for joining the webinar. My name is Avina Trzynski, and I'm a Senior Research Officer here at the Australian Indigenous Health Infonet, and I work on the Australian Indigenous Alcohol and Other Drugs Knowledge Centre project. Today I'm very pleased to introduce you to our guest presenter, Dr. Raewyn Mutch. She's a consultant paediatrician and she works at the Refugee Health at the Department of General Paediatrics at Princess Margaret Hospital for Children, and she's also a clinical associate professor at the School of Medicine, Dentistry and Health Sciences at the University of Western Australia. In addition, Dr. Mutch also works at the Alcohol, Pregnancy and FASD department at Telethon's Kids Institute, which is based here in Perth as well. So for today's webinar, our theme is the prevalence of FASD among youth under the care of a juvenile justice in Western Australia, and how shall we work together to close this gap? After the presentation, we'll have about 10 to 15 minutes for some questions. So we ask that they're saved for the end, and then you can pop them in the chat box at the end. Just a reminder, we're being recorded today and we'll make it available in a couple of weeks' time. You'll see it from our homepage. I would like to now hand over to Raewyn to begin our presentation.
Yeah, hi everybody. I will try to not talk too fast. Okay, so, oh, is this going to work? Yep. Thanks. So I too want to acknowledge the land on which we are sitting, the Noongar Nation, and we're a bit further away from Derwent right now, but I'm clearly a Kiwi, but I've lived here for a long time, and I've had a very privileged life here. So the stories I'm going to tell today in some ways aren't my stories to tell. I'm presenting on behalf of my team, and we've been led by Carol Bauer, who's an amazing person. She's asked me to talk initially about fetal alcohol spectrum disorder in general and about the new diagnostic tool. So if many of you know about that, I'm sorry for repeating that. I then will let you know about what we did with our Banksia health study. So alcohol's a teratogen, the same as radiation, the same as you might know with thalidomide, and any exposure to alcohol while you're pregnant can have a negative effect on the way the baby develops. And animal studies, the most extreme versions of that, show that the higher the dose of alcohol, the more damage there is to the brain. So this is from Karen Selleck's team, and we often show this imaging. This is a happy mouse with no alcohol. This is some alcohol. This is lots of alcohol. So you see the change in the mid-face, you see the change in the size of the brain, and you get this commensurate change in brain volume. That's the extreme version, but we know that that happens too in humans when we're exposed to that during our developmental time in the womb. So we don't know how little alcohol is safe, which is why we say no alcohol is the best option. We do know that excessive alcohol can cause more harm, and we know that binge drinking is harmful. But we don't know why, we know for some reasons, but amounts of alcohol exposure across the same time of pregnancy will affect different women differently, and that's about their nutritional state, it's about their trauma state, it's about their enzymes in their liver, it's about many other factors within the mother and within her social setting that changes how that alcohol then affects the child. Babies in the womb don't have the capacity to metabolize alcohol. So we know that for research purposes, and a lot of this work's come from Colin O'Leary, the timing of when the alcohol exposure occurred, how frequently it occurred, and the quantity has these deleterious effects. This is an old comment, but still true from the overseas, telling us that alcohol really has profound effects on the way children develop. That picture on the bottom right hand of your screen is a child with quite profound effects of alcohol. So has a small head circumference, has the long smooth philtrum and the small volume in the upper lip. That's the old-fashioned picture of what we used to call fetal alcohol syndrome. We no longer use that term in Australia under the new Australian Diagnostic Guideline. In contrast, it's not going to work, is it? Thanks. In contrast, this is a representation of a healthy baby, so has the larger head shape, has the wider eye openings, and has normal mid-face. So back in 2009, I think it was, the National Health and Medical Research Council changed its guidelines to tell us that we shouldn't consume alcohol while we're pregnant, and ideally we shouldn't consume alcohol if we're planning a pregnancy. Similarly, we should not consume alcohol while we're breastfeeding. This is some of the data from 2013 in a household survey showing that a large percentage of women consumed alcohol before they fell pregnant and then continued to consume once they knew they were pregnant. And we also know that around about 50% of pregnancies are unplanned. So even if in a well-informed household, there is still a risk of having alcohol-exposed pregnancies in our society, at least because of the prevalence of how we use alcohol as normal practice in our daily lives. This is an image just to remind us that alcohol has an effect right across the pregnancy. So if you look at the WA Developmental Anomalies Registrar, you'll see that there's data there around birth defects for the heart, for the kidneys. There is an increased incidence of those with prenatal alcohol exposure, but the thing we're really worried about with FASD is how alcohol changes the way the brain grows and then how the brain functions. Historically, people were more interested in understanding the effects of alcohol by looking at the changes in the way a child looked, and that's attributed to the way alcohol changes embryology. So this is a picture of the embryological buds, and as we go through early fetal life, those buds come round and they form the mid-face structures. So of interest for fetal alcohol is the upper lip, the nose, and the eye opening. And you can see that those tissues come around and form those structures. It doesn't form the lower jaw. And interestingly, those are the structures that develop differently when there's early prenatal alcohol exposure. So we can measure those effects. We can measure how big the eye opening is. We can take photographs and make those measurements. We can measure the upper lip volume. And we can look for other signs on the body that we know are associated with prenatal alcohol exposure. So changes in the little finger, changes in the way the ear is shaped, it's called railroad tract ears, and changes with markings on the hand. What we can't measure easily is how the brain functions, and exposure to alcohol right through pregnancy can change how the brain functions. So now in Australia, there's the new Australian Diagnostic Guidelines, and they've removed the term fetal alcohol syndrome. So that's about the syndromic looking kids who have those changes that you can see easily. Now we talk about it as a diagnostic term. Before it used to be a kind of a clinical grouping. Now it actually is accepted here in Australia as a diagnostic term, and we say that you have FASD either with the three facial features that I've described, so that's the small eye, the long lip, the long philtrum that's quite smooth, and the thin volume upper lip, or you have less than those three features, so you're one or other category. The important thing to know is that we understand that most people with a fetal alcohol spectrum disorder may not have any of those features I've just shown you. They may not have easily noticeable smaller eyes, they may not have the changes in the philtrum, and they may not have a difference in the size of their lip, but they can still have a brain behind that typical looking face that doesn't work normally because of the prenatal alcohol exposure, and that's one of the most important messages to now get across. So you can only have FASD if you've had prenatal alcohol exposure, and you may or may not have those external features, and you can only have FASD in Australia if you've had prenatal alcohol exposure plus you have to have 3 measured areas of function that are -2 standard deviations away from normal. And we look at about 10 different ways a person can function. Most of them are about how the brain functions, and I'll get to those in a minute. And the reason for saying you have to reach as far as -2 standard deviations is because that really is quite severe disability in that domain that you've measured. So as I said, most children have typical looking faces, but they have these non-typical behaviours. They have behaviours that you might think look a bit like something that you know under another name. They might be behaving like a child that you recognise more easily as having ADHD. They might be behaving as a child with features that you think are autism. They might be behaving as a child who has speech and language difficulties. Those diagnoses may also apply, but the important thing is to consider as to whether this may also be a presentation of FASD. And why that is important to consider as well is because if you can identify that the changes in this child and the difficulties that they're having with behaviour are attributable to that prenatal alcohol exposure, you can do one of two really important things. Firstly, you can find and work with the birth mother and see what it is in her family circumstances that have caused her to use alcohol during her pregnancy. It may have been accidental exposure, or it may be exposure that occurs because she has alcohol dependency issues. And if you're able to engage with her and work safely with her and help look at some of the drivers to why she has those difficulties, you may be able to have subsequent pregnancies that aren't exposed to alcohol. Secondly, if you determine that the behaviours you see in the child are more than only ADHD, but are actually FASD, then you may also look at the siblings of that young person and also consider them for a diagnosis of FASD. This has really important meaning in Australia nationally because we now are hoping that FASD will be considered as a disability under the National Disability Insurance Scheme. Not so much the name, but the fact that you've determined that there are 3 domains of severe impairment will entitle you for care under NDIS. And here, at least in WA, and I think there's a move nationally, if a young person's diagnosed with FASD, then they will be considered differently or more equitably before the courts. So there are many reasons why it's important to include in your differential diagnosis, does this person have FASD, and not just stop at your first diagnostic assumption that it's only ADHD or it's only a speech and language impairment. So FASD occurs everywhere. I've seen FASD in children within my refugee clinic. It occurs anywhere where families drink, and it's important to know that although it's about the mother drinking, it really is about the family drinking. And many women drink because they have to keep company with their partner, and they get into trouble if they don't. So it's about our social context. It's about the social determinants of health, and those are the things that we need to ask about more broadly. It's not about laying blame, and it's about restoring respect to women and helping them become healthy and helping their world to be more healthy than what it is. Internationally, the figures reported, as you see there, some are extraordinarily high within specific communities in South Africa, and our rates here in WA were found to be high as well. In a report that we did looking at data from the Birth Defects Registry, we compared the last 30 years and looked at the last 10 years to the 20 years before that, and found that the rates had increased across the whole of WA, and that's for reporting for FASD. The rates still remained high amongst people that identified as Aboriginal Torres Strait Islander, but that also reflects many other things, which is whereas health systems historically have had that racism actually, of only looking for it in that population, and we need to look for it more broadly in other populations. So how do we diagnose FASD? In Australia, we ask that you use the gold standard, which is that ideally you have a cohort of specialists like this working as an interdisciplinary team to measure what a young person can and can't do. If you don't have these diagnosticians within your area, you can look at ways to problem solve that. So if you're remote and you have access to an educational psychologist, they'll be able to unpack quite a few measures in what a young person can do. A general paediatrician that's been upskilled and looking for not the outward signs, but taking a history of red flags for behavioural difficulties that are signs for those early learning difficulties, impulsivity, can assist with the diagnosis of FASD. I think you still need to have a speech pathologist to determine what this young person can and can't do, and that's especially important in a juvenile justice population where we found a very high prevalence of language disorders. And an occupational therapist is important not only for the diagnosis but also in helping looking at therapeutic interventions to make this young person and their family's life better. So in Australia, that's a link at the bottom which you'll be able to click on it, but maybe not. But just go to the Telethon website and you'll be able to download the diagnostic method, and probably these guys will put it up on their web here. These are the 10 domains we meant to measure. For our study at the prison, we weren't able to do affect regulation because that really requires the input of a psychiatrist, or we could make comments on affect. And for adaptive behaviour, we found we couldn't measure that easily for 2 reasons. The young people in the prison really have their adaptive skills applied for them. They have a timetable put about them. They have regular meals, they have time to go to bed, time to get up, to get dressed, places to put their washing. We also struggle to find their extended family group that could help us fill in questionnaires about how they manage their day-to-day life outside of Banksia. And many of the questionnaires that are used for adaptive function are not helpful, such as you could ask, an example was asked, does your son empty the dishwasher? And the parent said, yes, he does empty the dishwasher. So then the next question was, do you have a dishwasher? And they said no. So the questionnaires just aren't suited for many of the young people in our country. And there is another way for measuring adaptive function that was made by Camilla Pestel. She's a life skills checklist. But actually I think by the very fact that you are sentenced to prison, or actually by the very fact that you come into contact with the law, should in itself be a marker that you are adaptively impaired, and that domain should be given to you. So FASD, you can be diagnosed with FASD without meeting severe impairment, like with having a normal IQ. You can have a normal IQ and still have FASD. But for the purposes of our study, we had already decided that we would accredit young people as having profound impairment if they were -2 standard deviations. And during the course of our study, the first iteration for the FASD diagnostic guidelines were changed and then made the guidelines that they are now. And that just happened to also suit the fact that we'd already done -2 standard deviations. So the reason for putting this graph up here really is that if you're any of those stars, if how you test any of those stars, you may not have impairment necessarily attributed to you, but life is pretty hard for you. So if you have fetal alcohol spectrum disorder, you'll have a variety of behaviours that can mimic other conditions, like I've already said, like ADHD and so on. The key problems with many of these children are around their impairment in executive function, around their memory and learning difficulties, their speech and language difficulties, and their impulsivity and hyperactivity. So if you have any of those problems with your behaviour and inability to do any of those well, then it's not surprising that that leads to early school failure, and then very rapidly the secondary problems of mental health issues, poor self-esteem, and early engagement in drug and alcohol problems. That then, of course, leads to early engagement with juvenile justice. And nearly every young person we met out of the prison, they had early school failure, and they were not recognised during that time as having a learning difficulty. They were, I think, assumed just to be naughty. We don't really have the actual data for that, but it seemed that they never were afforded an assessment at that time. And when they left school, they very quickly fell into using substances. So a young person with FASD doesn't intend to behave the way that they do. It's a sign and a symptom from their permanent brain damage. So the consequences of not having your FASD diagnosed are profoundly far-reaching. They are the loss of education, as we've mentioned, and therefore the loss of opportunities, the loss of normal social engagement, the loss of fulfilling your dreams, and in time the loss of hope. These listed problems are exactly the same as the Australian Bureau of Statistics looking at what are the consequences of early engagement with juvenile justice. In fact, they are word for word the same. So in Australia, we didn't have any data before our study about what the rates for FASD might be amongst young people that were in prison or in detention. We knew from overseas the rates were considerably high. Certainly the rates were very high for any form of engagement with juvenile justice, as high as 60%. And just this week, a colleague of ours that we know, an international colleague that we know, has just released her report showing that there's a 17.5% prevalence of FASD amongst their correction population. But in communication with her, she said the rate would be considerably higher if they could have confirmed definitively the prenatal alcohol exposure. It would have brought it up much, much higher. So our Banksia health study was NHMRC funded. It was initially funded to target the prevalence of FASD amongst sentenced Aboriginal and Torres Strait Islander children, and then we had a dispensation to look at FASD amongst any young person that was in detention. And then in discussions with corrective services, it was decided it was best that we only looked among those young people that had actually been sentenced and not the ones that were remanded, because there was an unreliability about how long the young people in remand might stay. Some actually stayed a very long time and could have been in our study. Others might be there for just a few hours, which is why it stayed that we just looked at those who were sentenced. I have to tell you that we need to acknowledge the disclaimer that what I'm telling you is from our study and doesn't necessarily support the views of the Department of Justice. And I need to acknowledge the children, young people, their families and carers who participated in the study. It's my hope that their gift of participation may be able to change how their lives have been and may be able to change the lives of young people across Australia. So we had to consult widely with communities, most importantly with Aboriginal and Torres Strait Islander community because of the inequity and the overrepresentation of Aboriginal and Torres Strait Islander peoples within our juvenile justice system. We had a very large team who helped us do this study, and they're all incredibly important. So we wanted to look at the prevalence of FASD. We're still there actually with the workforce development. Hayley Passmore is completing her PhD and is doing phenomenal work developing resources to help custodial staff work even better with young people who are detained. And Sharon Hamilton, who couldn't be here today, has done amazing yarning with young people and with community and stakeholders about what it means to have been part of the study, but also what it means to have your family going through juvenile justice. It would have been great if you could have heard from her today. This is our team, and this is Hayley, who's doing the workforce development. This is Sharon, who did the yarning, and this is the fantastic Carol. This is Nat, who did speech and language. This is Bernie, who did the occupational therapy. Jacinta did the hard yards of finding the families and asking the really hard questions about prenatal alcohol exposure. And Noni helped herded the cats to keep us all in line. So the young people that we see came from all over the state, and we could have enrolled more than what we did. We had trouble. That was the fence we walked through every morning to go and do the study, and I'd walk through that every night and think I'd want to sleep outside if my daughter was in there. I couldn't think of leaving her behind. Okay, so that's us. We did that, and that's Hayley's paper, who wrote up how we did our study. Yeah, so we could only study within that age range, and so we had standardised testing to look at that age range. And there are actually young people who are there older than that now. They don't go through to the adult system if they don't have long to spend on their sentence. We had to get assent from the young people, and then we had to find the responsible adult to get a written consent. We'd often get a verbal consent from the adult, and at times it was incredibly hard to get written. Jacinta at one time sent a fax through to a petrol station way up north, which was still 2 hours from where the Nana lived, and then she was driving through on the way to get some food, sort of 4 hours away, and was able to sign that consent form. That was an example of the links that we went to get written. We were unable to get written consent on about 43 young people who could have been part of the study. So we got complete data on 99. The majority were young men and young boys, and the average age, as you see, there was 16. So as I said before, the majority were Aboriginal and Torres Strait Islander youth, and then you can see the other ethnicities as the young people self-identified. The majority were actually metropolitan young people, and then you can see the numbers who came from around the state. They're a long way from home. They're a really long way from home. And they're a long way from healthy. And they've been a long way from healthy for a long time. And whereas the health system and the education system have failed to meet their needs. So, Jacinta did the proximal interview. I repeated many of these questions when I did my own clinical examination of the kids. And we wanted to know about what their world was like, what they did, what made them happy, what got them into trouble. We couldn't actually ask what their offence was. Often they'd tell us, but we weren't allowed to ask, and we didn't ask. They'd often tell us about what their life was like, and in doing so, and especially for me, where I always draw a genogram of a young person when I meet them, I ask who they are, I ask about their siblings, and I ask about the world in which they live, and by the end of that conversation, I actually have a genogram of trauma, and that was common to everybody that we met. So Jacinta used the audit C to ask about their alcohol use, and that's not an easy conversation to have with anyone at any time. It's particularly difficult when you're asking somebody about a pregnancy they had 15 years ago or 12 years ago. And sometimes those conversations happened over a number of days, months, weeks, and sometimes the stories changed. Often there would be no, I had no alcohol, and then when we came back to feeding back the results, often then the story would come out. And that's a common finding, I think, any of us in our clinical practice. I know in my child development work, only with time, as they felt they could trust you and as they began to see the difficulties that their children had, but were hopeful that you could help them make a difference, that then they may be brave enough to share with you that they had struggled with prenatal alcohol. And I think you have to always be open to hearing that and profoundly careful and never casting judgment, but walking with people as they tell you that story. So there are limitations in doing the study. It's clearly a hard to reach place. We couldn't do the adaptive function testing, as I mentioned before. We ended up finding that the work that we're doing ended up having a forensic impact, and actually I ended up giving evidence about a young man, and that's actually changed the law in the state. That wasn't the intention with which we did the study. It's a positive outcome that's changed the law in the state, and hopefully will change the law nationally. But I remember the day I gave that evidence, and this young man had undertaken a very serious crime, that I had just left a ward round where I'd seen a young person on that ward round who had been subjected to a similarly serious crime. So it was hard to be in those two different worlds, and I encourage you, if you're going to undertake this work, to have really strong systems of self-care, but don't pull away from that work. This is profoundly important. We can help change the lives of young people who have been missed to date. Our neuropsych testing was completed by postgraduate students and supervised by Camilla Pestel from UWA. They were amazing, the students that came through. We had them for a long period of time. They each brought something different. They each changed how we worked as a multidisciplinary team, and what domains there you might think came up the most frequently impaired, and just in your own mind do an ascending order. The next slide I'm going to show you has no data on it. I'll just list them, but the way that I list them is actually in the ascending order of what was the most frequent down to what was the least frequent. So I'll just give you, like a second to think about what you think we found most commonly. And this is a question for all the kids that we assessed, not just those with an FASD. What do you think? Executive functioning? Okay, all right. So actually academic was the biggest hit. Yes, the reason I've had to take the data out is because we're just on the verge of publishing our prevalence paper, and if I somehow trip up and publish this somewhere, I'm going to be in big trouble. So hopefully before these slides come out, if the paper's published, we can just populate this graph for you. But of all the kids, academic was the worst. And this isn't just about the fact that they stopped going to school. This is actually they are physically unable, their brain is unable to do academic juggling of ideas. And next, executive functioning, again, a really high prevalence. And then attention and processing speed, language. So it's not surprising that, if we think from here up, it's over half, over 50% have these in high prevalence. Then how does that work with you managing life? How does that work with you managing the education system? And how on earth does that work with you with having the law applied to you equally? If you are impaired across all of these things, did you have any idea of what was happening to you when you were being interviewed by police or going through a legal system? So again, I want you to think about how they might list up if you had a diagnosis of FASD. What do you think would be top of the pops, and how frequent do you think they might be? Okay, so I've color coded this. Basically, if it's this color red and pretty much there, it's more than 50%, and we're looking in this -2 standard deviation. So I tested -2 standard for academic. I tested -2 standard deviations for executive function. I tested -2 for attention, -2 for language, -2 for memory, -2 for motor. These are extraordinarily high levels of impairment and 50% of our population had 3 or more domains impaired, irrespective as to whether they had FASD or not. More than 50% had 3 or more domains impaired. That's extraordinary levels of disability that, without the serendipity of our study, would never have been diagnosed. Here we're looking in the 30% and 20%. Okay, so it's a world first study, and this figure is actually higher. Now, this has been published before, which is why I can put it here. This figure is actually higher. What we do know is that of the young people that we study, they are actually a representative sample. We've gone back and compared it to who could have been studied. So it is actually a representative sample, which makes this even more powerful. And again, I've colour-coded this. We weren't allowed to directly ask about lived trauma, and these young people would just tell us about what their life was like. And you can see, again, over the 50% it's really high levels, over the, in the 30% it's really high levels, and then not much lower than 30%. So really high levels of them, just in the course of them talking with us, telling us about these adverse childhood events. And we know from research overseas that if you've got 4 or more ACE, 4 or more adverse childhood events, it has a profound impact on your early morbidity, early onset of cancer, early onset of drug and alcohol addiction. We know that at a genetic level, it has epigenetic effects which you then pass on to your children. And if we're looking at the high level of incarcerated Aboriginal and Torres Strait Islander children, we know they've already come from a background that's been colonised and traumatised and had land taken and language taken. So they're already coming into this with possible epigenetic changes, and then these other events happening. So this is a study of profound need, and both in prevention and diagnosis. I haven't put the data there for what we found for physical and mental, but about 80% had abnormal physical exam. I found something wrong in about 80%. I saw them blindly as such. I didn't have any blood results. I didn't have any past medical records. I was really just seeing them as a person in the room and examining them after having talked to them about their world, talked to them about symptoms, and then examined them. Nearly all of them had dental caries. About 20% had metabolic issues, either too skinny or overweight. Quite a high percentage had acanthosis nigricans and other markings for type 2 diabetes. Many had musculoskeletal anomalies from injuries that occurred either during arrest or during high-risk behaviours that hadn't been rehabilitated properly. As you know, many of them had that consistent story of leaving school early. So they'd be struggling at primary school but not going unnoticed, and really coming to attention at that first year of high school when there's that more didactic approach to learning and the need to change classrooms. That's when their learning disabilities and their executive function couldn't manage those environments, and they arced up and they left. And only a very small percentage made it through to year 12. Most had left by year 9. They had as routine trauma and grief in their histories, and yet in spite of all of that, they still were hopeful. And I would like to think that we going forward could work with them to realise their hopes. As I said before, language was a huge factor of difficulty in these young people, and Natalie Kippen is doing her PhD on this work now, so I can't go into too much detail about this, but she brings learning from New Zealand and England, where they use people who are language specialists to work with young people in the court system and the judicial system, and I think that does need to occur here because of the prevalence of language inability in these young people. And we considered them in the context that English may have been their third language. We got interpreters to help us if their first language was their strength, and we worked with interpreters to measure how they worked in that first language. There were 7 of the first languages for WA were spoken by the young people that we worked with. So that's our study, and I think all of us in the team hope that this information will help bring change. I love Brian Stevenson. I recommend him to you. He was in the top 100 Time magazine a few years ago. He runs the Equal Justice Initiative in America and works with getting people off death row. He actually came out here at the Writers' Festival a few years ago, but I like how he says that we measure our society by how we treat those that are accused and incarcerated, and that we are all implicated when we allow other people to be mistreated. We spend an enormous amount on youth justice, and in Australia we incarcerate young people from as young as 10. The World Health Organization says we shouldn't consider criminal culpability until at least the age of 12. And if you look at the money per year in WA to incarcerate one person, I look at how that money could be spent on education, rehabilitation, drug and alcohol treatment, grief and trauma, bringing cultural strength back to these young people. That would be a far better way to spend that money. We know the statistics in Australia for incarceration are worsening. So in brackets is the Australian Institute of Health and Welfare data from the 11th and 12th, and now from 15-16 you look at those numbers increasing. And I think you'll all know that the Closing the Gap report said the only gap that's closed is more children are staying into the end of year 12. Certainly this gap is widening. Nationally is a cry that it needs to be different. We need to do differently. And during the time of our study, there were the reports, not just here in WA, but around the country, of problems in juvenile justice. And of course, what gained most world attention was the events in the Northern Territory at Dondale. We have a long habit of abusive treatment of Aboriginal and Torres Strait Islander people when it comes to injustice. We look aghast at how people with behavioural difficulties are treated overseas and think that this is done poorly. We now know that we have done similarly here, and that has prompted the Northern Territory inquiry. I recommend to you the reports if you haven't read them, and the stories contained in those reports are the stories that we heard here, and I would think they're the stories that you would hear in any state in Australia. And the trouble is that once you see it, you can't unsee it. And once you've seen it, you can't stay quiet. We are all accountable. And Frederick Douglass was an African-American man who was a free African-American man during slavery. And his quote is, "It's easier to build strong children than to repair broken men." I made a video, it's just really like a PowerPoint with music behind it actually, that's the link to it, about Australian juvenile justice. That's now embedded in the Restorative Justice website in ANU, and it's gone as far as the Canadian Bar Association and the American Bar Association, saying it's a useful video. It's really advocating that any young person that comes before juvenile justice should have a multidisciplinary assessment to determine what they can do well and to develop therapeutic plans to change their life for the better. The music on that video is from Mr. G, who's passed away, and I have permission from his family to keep that music on the video, that it can be heard and have his name on the video. So if you spare 5 minutes, have a watch, or use it to people that are going to fund your diagnostic service. So our Australian Human Rights Commission tells us that this is a one in a generation opportunity, and Mick Gooder tells us that our young people don't belong in prison. William Wilberforce, another man against slavery, tells us we can't look the other way, because we now know. We now have Australia on the Human Rights Commission, and I love the Convention on the Rights of the Child. I think it's a wonderful document, and I use it in advocacy for what I think is required for the children that I work with. But the conventions there that are bolded are actually part of Australian law, and they can be used to change things. And interestingly, those that are bolded are for the rights of Indigenous people, the rights of people with disabilities, and our federal government's about to sign OPCAT. All three of those apply to the young people that end up being incarcerated. So I hope that now with someone on the Human Rights Committee and with these very powerful documents that are part of law, we might be able to use mechanisms to bring change through law. So in WA, in our bench book, the Chief Justice has embedded in our bench book information about FASD so that young people can be treated differently. And the case I talked about went to the WA Supreme Court of Appeal and is now part of law. And actually the Australian-New Zealand Psychology and the Law Conference just happened at the end of last week here in Perth. And they spent an entire morning looking at that case and using it as a teaching for how we need to consider people with neurodisability and actually with FASD before the law nationally. And they also referred to the Pora case from New Zealand as a teaching moment, and Valerie McGinn, a neuropsychologist from New Zealand, took that case to the Privy Council and helped show that FASD is important and needs to be considered. Professor Harry Blagg here and Tamara Tulich has worked closely with communities in the north of our state to look at diversion. Just last week, the White Ribbon Foundation, the Healing Foundation, put out an excellent document which I know we'll put on, it's on actually this website, and I recommend that to you. There are stakeholders across our state that are looking at doing things differently for our young people. I'm sorry I can't talk about what is happening in the other states, and Amnesty International is across this at the moment here in Australia. These are really important people. This is our Chief Justice. This is Rachel Green, who's high up in community services now, but was high up in Juvenile Justice. These are our Aboriginal welfare officers out of the prison. These are the young people in the circumstances out of Banksia, and this was the Minister. They're all on board now here in WA, hoping that things will be different. We just need funding. And that, again, has come out of our project. By us being a presence on the ground, has helped shift people's belief that things can be different, and has shifted people's belief that it matters to know whether a young person has difficulty with their learning and memory and may have a neurocognitive impairment. So we have people across the state too who really want to see things different, and we have people, as I said, nationally, internationally, that would love to work with us. We just need funding. Hayley, as I mentioned, she's still on the ground out at Banksia, and she's developing resources through really excellent work. She shadowed the officers out there for their 12-hour days for about 7 months. She's done knowledge, attitudes and practices studies about how they feel. She's done qualitative interviews with the young people about what it means to be managed for their poor behaviours out there. And now she's worked with a very respected documentary film team who's done a lot of work remotely, actually with remote communities, to develop videos from the young person's perspective of how it feels to be managed for their poor behaviours. And she's going to roll them out early next year and evaluate them to see if they can change the way that young people are cared for in custody. Okay. So this is the White Ribbon Healing Foundation report. And as Menzies has got some really good stuff around, and that again is on this website here. We've got great stuff around mental health. And this is from Queensland, and that's from Amnesty International. So I would like to see us do this. I really would like to see us do this and have communities tell us how we could do things differently. Because honestly, if we keep doing the same thing over and over, it's going to be no different. And we can't solve the problems by thinking the way we have, which got us there in the first place. Our FASD hub is useful if you're looking at resources for FASD. And although that was how the study started out, I think now we have to think more broadly. These are about young people with neurocognitive impairment. Clearly, FASD is a very significant contributor to that, with this conservative prevalence of 36%. We know it's higher than that, but conservatively and scientifically, we could settle on that number. The FASD Hub website has these videos that you can read that are really helpful and really powerful, with telling stories about what it's like to have FASD and things you can do to make lives better. And that's a quote from my Ngāi Tahu tribe, and that's a quote from the stone outside Telethon Institute, which is in the Noongar language. So I'll leave it there. Afterwards, there's just a few slides on just reminding you that you need to reframe behaviours and think differently. And you can download these from anywhere, actually, on any website. And the concept of reframing, this is about a tool for autism, but it can be used with kids with executive dysfunction anywhere. And we're back to here. So, great. Any questions? Can you help me with that?
Yes. I wanted to say a big thanks for that quite moving presentation. I wasn't expecting that. Thank you, Raewyn. That was wonderful. I would like to open up the floor or the chat box for people who would like to ask questions. As you can see on the slide there, we've got our Knowledge Centre FASD portal, which also has lots of information. We do try and find the most Indigenous specific information, so that'll include policies, key facts, publications, resources, programs, etc. And as Raewyn mentioned, the FASD Hub as well has a fantastic national resource for whether you're in research or you're a parent or a carer, you're a health professional, etc. Okay, so we're just waiting for a couple of questions to come online, and you can come back into the picture if you like, see if we can see everyone there. I've got someone typing. I might just see what the next slide is. Here we go, and some contact details there for you. You can contact me or Raewyn if you have any further questions. And a reminder that we are recording this, so it'll be available on our website if you want to go back and revisit, and we'll make the slides available as well. Okay. Good. All right. I'm just going to read these out so everyone can hear. Thank you, Raewyn, for the great presentation. I still have a question about the accuracy of diagnosis of FASD based on the severity, specifically how accurate ICD codes are for diagnosis, and that's from Armita.
So I'm not sure why you're asking about the ICD codes. We use the FASD guideline that's been developed for Australia, and some of the different domains that we looked at and said it can only be severe if it was -2, is not consistent with some of the specific disciplines. For example, some of the speech and language people will assign for certain attributes an impairment if you're only -1.5. So we were using the FASD, Australian FASD diagnostic guidelines, not what you're asking there, I don't think. I don't know if that answers your question. Yeah. I know what you're asking, but we didn't use those.
Okay, so we've got some...
Kapai.
Okay, Anita Gibbs. Thanks, Raewyn Kapai. Any chance of not using the mouse model pics people with FASD not overly keen? Also, people don't use the mouse model for neurodevelopmental impairments.
Okay.
Thanks for your presentation.
Yeah, that's interesting, that comment, because other times, I've done lots of teaching around the place, and I actually don't like the image of the post-mortem brain. It's really tiny, and in some ways, I think it's, and many of the MRI scans also are inconclusive and conflicting, but I'll take that on board and happy to take it out. We can take that slide out if you like. So I think it's really hard to show structurally the effect of what alcohol does, and it can seem quite nebulous. Yeah, but that's a really helpful comment. Thank you.
Yeah, thanks for your feedback, Anita. Next up with Sarah too. I'm interested in knowing about modifications on standard measures to assess kids that English may be their second or third language.
Yeah, so if the young person had English as a second or third language, so if they had Aboriginal English as their language, we were able to assess whether that was impaired or not. But if they had a traditional language as their first language, we might be able to determine that it was impaired, but we couldn't assign it for the purposes of the study. So there'll be more information come out about that in Natalie's work. And that was really difficult for us because we might have someone who had, say, 2 domains of impairment, but we couldn't give them a third because if we assess their first language. But if they have Aboriginal English as their language, we were able to make a call on that.
Great. Another question from Riley. Is there data regarding FASD and the cost to the health budget in Australia?
There's a hope that will be done. In fact, there's a hope we want to get linked data that goes to these young people and make some economic evaluation. There is work happening, I think, through the Centre for Research Excellence trying to answer that question. And there's been some postulations about it when I think Larry Bird visited. He made a comment about how much that might cost when he gave a talk several years ago now in Tasmania. But definitively, I don't think we have actual figures. But if you look at just simply, we've got, say, 36% of our young people have FASD and they're incarcerated. It costs, and amongst those, we had 20% with impaired cognition. So as adults, they would be entitled not to be incarcerated. They could be entitled to go somewhere else because of that ID impairment. So what's 20 times $360,000? That's enormous. it shouldn't seem to be too hard to make that kind of calculation.
All right. Thanks, Riley. We've just got a few more questions, people typing. Susan Burns, has there been any progress with FASD being recognised as a disability by the Australian Health Medical Board?
Yeah, so the name FASD alone, I think no. The fact that you can have 3 domains of impairment and be entitled to care under NDIS, then yes, but it doesn't really matter what your diagnosis is, it's just you have to prove 3 domains of impairment. If you've got FASD, so we have children from the study who have FASD, but they don't get care under disability services. We even have other children that we found had impaired cognition, but because we weren't able to measure their adaptive impairment, they too aren't being allowed to get care for under disability services. So it's a very fraught area. There's been a recent coronial inquiry occurring across the north of our state looking into suicide and some other issues, and scattered within that has been presentations by myself and other people, and I think there's an intention that that will be one of the recommendations, that FASD should be considered alone as a marker for receiving disability services, irrespective of what your cognition measures.
Thank you, Susan. I still have a couple more people typing. Hoping Claire will have her question up soon.
And just on that note, the FASD, when it was put in the bench book for WA, was put in Chapter 4, and Chapter 4's title is disability. So the legal profession was happy to put it into that chapter under that title of disability, while still medicine had not yet agreed for it to have the same label.
We've got a question from Claire Hilton. This presentation is very relevant to the NT following the recent release of the report from the Royal Commission in Youth Detention. I'm hopeful of raising the involvement of allied health within this critical role. Is there evidence of the benefits of using allied health professionals for supporting FASD in detention?
Yeah, so Bernadette is producing her motor paper. She's written it and trying to get that published. So, but she wasn't able to, I mean, what we're wanting to do, and we have agreement from Justice, is we'd now like to do an intervention study, but and certainly speech and language, clearly also there's a need for that. And it just doesn't make sense to me that it wouldn't be routine to have occupational therapists, speech and language therapists, and clinical psychologists working as a routine care and assessment as soon as a young person comes into court and comes then either into prison or into community care under justice. It just doesn't make sense to me that they're not there. Hopefully the data that we produce that comes out in our papers will be a means of proving that it's necessary. We were actually asked to make comment on the Northern Territory inquiry, and but specifically about saying you must have allied health people. Hopefully it'll come from our papers.
Yep, great. So we've just got a couple more minutes. If anyone has any further questions, feel free to quickly type now in the chat box. Or if you don't want to ask right now, you can certainly, you see the contact details up on the slide. You can contact Raewyn direct at the health.wa.gov.au email. Or if you want to ask me any questions around the webinars, that'd be great. I see a couple more people typing. Thank you, Daniel. Okay, well, I think what we'll do is wrap up. We're almost at 11 o'clock here in Perth. And so, of course, I wanted to thank very much Raewyn for coming in today and sharing this story and telling us about this Banksia project and its importance nationally, I think, as well, not just for Perth.
Shall I quickly answer that?
Oh, we've got one more question.
So, this is from Catherine saying, is there work known supporting paediatricians upskill to diagnose? There is on our FASD Hub website and Telethon website, there is mechanisms to help with diagnosing that. I'm also happy to have a phone conversation actually and talk you through the, in fact most of my colleagues will be happy to have it, and talk you through the diagnostic guidelines. So there's lots of ways to do this. And also I think recently there's been money won from the federal government to look at setting up a training course through uni, but you don't need that actually. You just need to have someone sit down or even buddy with you to go through a first multidisciplinary diagnosis, or do 5 or 6, and then you'll be up and running. So just email and I'll see where you are and see if we can get some people to help you.
Great, thanks Raewyn. Just before we head off, I'd like to let you know that this is our last webinar for the year, but we'll be back early next year, somewhere between January and March, for our next webinar, and we will post further details closer to the date and letting you know who that will be. I think we're about done here. Thank you very much for listening, and as I said, we've recorded this session, so it'll be available on our website with the slides, and we'll probably follow up with some extra links as well, just to let you know that on the Australian Indigenous Health Infonet site you can access the Healing Foundation portal, which is really important work around the stolen generations and trauma. There is our section around offender health and justice, so if you're looking for more information there, and of course the AOD Knowledge Centre has the FASD portal. So hopefully there's some really great resources for you to access after this session. And I think that'll be it, and we'll
Thanks
sign
very
off.
much.
Thank you everyone.